Today, we have the pleasure of hearing from David Sobel from New Hampshire in the US. He will be discussing the advantages of introducing the use of lasers into endoscopy and minimally invasive surgery. There's a lot to cover, as you can imagine, a lot of different types of lasers, different parts of the body. So we'll get started here as soon as I finish his introduction. Dr. Sobel began his veterinary training at the University of Glasgow in Scotland before returning to the US to receive his DVM from Tufts University, or Tufts Vet School, in 1992. He was on the staff of the Dover Veterinary Hospital, during which time he received advanced training in human endoscopic surgery at the New England Medical Center in Boston. He later served on the staff of the Hanover Veterinary Clinic before starting his own mobile practice, Metropolitan Veterinary Consultants, in 2000. Dr. Sobel was one of the first practitioners to begin incorporating the use of diode lasers into minimally invasive surgery for dogs and cats, taking what had previously been purely diagnostic procedures into the realm of interventional surgical endoscopy. He is a co-editor and author of the British Small Animal Veterinary Association Manual of Small Animal Endoscopy and Endosurgery, which is about to go into its second edition. And he's also contributed to Ettinger's textbook of veterinary internal medicine, as well as Winkler's Laser Surgery in Veterinary Medicine. And with that, I will hand it over to Dr. Sobel.
Thank you, Christopher. Well, first of all, thank you all for joining us this afternoon. Good morning, good afternoon, good evening, depending on where in the world you are. I want to give you a little bit of background as to how I've come to this. But first, I'd like to actually, there we are. I want to just echo some of the thanks that Dr. Chambliss already said. Thank you to the organizers, Dr. Tweet and his team at TMIS-CSU, for inviting me to speak with such an esteemed group of colleagues and speakers as have been collected for this series. It's really an honor to be asked to participate. So thank you to them. I also want to acknowledge professionally Karl Storrs for the help and advice they have given, not just me, but I think so many of us in the MIS community owe a tremendous debt of gratitude to Karl Storrs for supporting us for many years and really being instrumental in getting small animal endoscopic surgery to where it is today. In the interest of disclosure, I'll just point out a couple other people and companies that I've worked with. IPG Medical is a Boston-based, Russian-originated photonics firm. They do OEM lasers for a variety of industrial applications, scientific applications, and they are producing some diode lasers intended for surgical use, and they are trying to get into the small animal market. So some of the equipment that I use was graciously provided by them. Alexion, you see down there in the lower right-hand corner, is a German-based laser manufacturer. Again, they make a couple of different diodes originally designed for the dental market, as many of these pieces of equipment originally were. They also are looking at the veterinary market as a place that they can expand to. So thank you to them for their equipment support. Before I jump in and sort of talk about this, I want to give you a little bit of background as to how I came to this, because I do think it's relevant. I started, as Christopher said, I started doing laser surgery probably about 25 years ago, and it was really somewhat fortuitous. There wasn't a lot of information out there in terms of taking diagnostic endoscopy and performing more interventional and therapeutic procedures. A colleague of mine had a spouse who worked for a biomedical equipment company, and she said, here, you know, this is a diode laser. It uses a fiber optic delivery system. See what you can do with it. And I looked at the fiber and I looked at my endoscope, and with really no understanding of laser physics, laser safety, laser tissue interactions, I put that fiber inside my endoscope and I started doing surgery with it. Not the best way to undertake some new, novel, and while very helpful, potentially dangerous technology, but that's what we had back then. And as I recall, the first diode laser I used was, it's chair size. It's an enormous piece of equipment, and it was marketed as a portable unit because it had a handle on it, weighed about 100 pounds, not very amenable to what I do now as a mobile practitioner. Since that time, as so much of the minimally invasive equipment has gotten smaller and smaller, as evidenced by the Storz Vet Pack and other similar products, lasers have gotten similarly small. Diodes can now be desktop versions, not much bigger than a laptop computer. And the range of equipment that's now available to us has dramatically increased over the years. So why do we want to consider adding this expensive piece of technology to our repertoire? Well, some of these I don't have to really proselytize too much about, because some of these are the same rationales that we use for doing minimally invasive surgery. Indeed, less pain, less tissue manipulation, less hemorrhage, less edema. Most lasers, depending on the wavelength, and we'll talk about that in a little bit as well, are neurostatic, lymphostatic, as well as being hemostatic. So you'll be able to control pain better, you will have less postoperative swelling and edema, and certainly, depending on the wavelength, less hemorrhage. Cosmesis is certainly a concern. Obviously, it's less of a concern to us in veterinary practice, but the ability to perform surgery with less tissue damage allows us to potentially preserve cosmesis. There are those people, I'm sure you've come across some of them, who are doing NOTES surgery, natural orifice surgery. Again, one of the rationales being an improvement in cosmesis. Rapid return to normal function. This has certainly been demonstrated in minimally invasive surgery over many, many years. But again, the less aggressive the surgical intervention, the more rapidly our patients will return to a normal quality of life. Excuse me. And marketability. This is something I try and talk a lot about. This is not inexpensive technology. It does take a little bit of time to learn, but the rationale for adding this to an already existing endoscopy or MIS set of offerings in your own clinic is the synergism. The ability to take the equipment that you might be using for somewhat limited applications. Again, if you are in a primary care practice, you may be limiting your endoscopy to diagnostic endoscopy, which is incredibly important. But to be able to add on a relatively manageable piece of equipment to expand the offerings that you're able to give to your clients really underlies the principle of being able to maximize the economic value of what we do. Obviously, good quality endoscopy equipment is not inexpensive. And in an effort to make sure that we are really maximizing the return on the investment, it behooves us to try and find increased applications for that equipment. And lasers certainly take you into a realm where, with minimal training and minimal experience, that you can really expand the offerings dramatically. Of course, the disadvantages, as I already alluded to, the cost of the devices. And diodes can be found on the used market for as little as $2,000, depending on the product, all the way up to probably $40,000 or $50,000. Holmium YAG lasers have come down dramatically in price. We'll talk about them a little bit later. They range anywhere from about $30,000 or $40,000 up to close to $200,000. So these are not inexpensive pieces of equipment. The disposable cost is also something that needs to be taken into consideration. The fibers that we use in minimally invasive surgery are oftentimes proprietary to that particular device. Many of them are designed for single-use applications. We in veterinary medicine are really good at squeaking out a couple extra uses, and most of the fibers that I have managed to use over and over and over again. And we'll talk a little bit about fiber choice and management in a little while. Learning curve, as well as the next bullet point under there, the potential for thermal injury, it probably should go together. One of the things that I caution people against is the assumption that a laser is a laser. So if those of you who are doing a fair bit of general surgery may recall back in the mid-90s, and maybe I'm just dating myself, but when carbon dioxide lasers came onto the veterinary market and really proliferated, the availability of low-cost, good-quality carbon dioxide lasers expanded dramatically. And they were selling an awful lot of them. But I think it becomes one of those situations where when your only tool is a hammer, every problem becomes a nail, if I'm using that phrase properly. People are trying to make this thing fit into places that it really just should not have been used. More problematic is people were taking their experience with carbon dioxide lasers and trying to make it applicable for use with diodes and neodymium YAG lasers and things of that sort. A laser is not a laser is not a laser, and I can't reinforce that enough to you. Lasers behave differently depending on proprietary technology, depending on the power, depending on the wavelength. It's probably the single most important consideration in deciding which laser you're going to use. And it is not simply a matter of efficacy, it's a matter of safety. Inappropriate use of the wrong wavelength of laser can have significantly deleterious consequences. And we'll talk as we go forward a bit more about how to choose the appropriate wavelength for the specific clinical indications. As I mentioned, the market was really set largely by carbon dioxide lasers. The technology has been around for a long time. In the mid-90s, following a proliferation of used equipment that was on the market that veterinarians started buying up, some of the primary laser companies in the United States and in Europe started OEM marketing carbon dioxide lasers directly to the veterinary community. And as I said, they were wonderful devices, very, very helpful for general surgery. They are not as applicable in most cases for minimally invasive surgery as some of the other products that we'll talk about. But they really set the tone for the interest in the use of lasers in small animal surgery. It's worth noting that some of the carbon dioxide lasers now have aftermarket technology that allows the waveguides that they use. Of course, carbon dioxide lasers don't use a fiber optic delivery system traditionally, but they've managed to sort of jerry-rig some technology to allow a slender waveguide to go into an endoscope. I still think it is sort of trying to fit a square peg into a round hole. If you have a carbon dioxide laser, I'd encourage you to explore that possibility, but the other things we're going to talk about are going to be a little more specific to us as endoscopic surgeons. Probably the most common laser that we saw in the fiber optic world that was applicable for minimally invasive surgery initially were the neodymium YAG lasers, really picked up more by the equine community for doing upper airway surgery in horses. They were probably ahead of those of us in small animal practice by a bunch of years. Neodymium YAGs are great lasers. You can find them on the used market very affordably. Holmium YAG lasers are one of the newer lasers that have come onto the veterinary market. As I said earlier, price has been a factor for them. They started out well over $100,000, making them somewhat prohibitive for many veterinary practitioners. They have come down dramatically in price over the years, and they are now trickling out onto the used market, and they can be had for reasonable sums of money. Just as an aside, I don't have a list there, but Tulmium lasers, Tulmium YAG lasers are the next generation beyond Holmium. They are great soft tissue lasers with also the added advantage, similar to Holmium, of being able to be used in lithotripsy and laser lithotripsy. There is in bench evidence that supports its better technology for lithotripsy that has not been well demonstrated in outcomes-based research in the human field. So that remains to be seen. One of the companies that I'm doing some work with is trying to bring a Tulmium laser to market that will be more cost effective for veterinary practitioners. Diodes are certainly the workhorse of most of us who are doing laser surgery in small animal practice. They are, as I said, they are small devices, many cases. The fiber optic delivery system interplays with our endoscopic equipment beautifully. And depending on the wavelength, we can really control the laser tissue interactions. And as I alluded to before, from a cost perspective, these devices can be had for anywhere from $1,000 to $2,000 on the used market, up to $50,000 and upwards in the new human products. We'll talk a little bit, but a diode is not a diode. As I sort of mentioned before, we want to be very cognizant of the wavelengths that we buy. Commonly, the wavelength that we see most frequently in veterinary practice is 980 nanometers. I use 980. I also use 810 with frequency, and they have different thermal effects, which we'll get into. Very quickly, PDT diodes, for those of you who have been doing some of this work, particularly in academia, photodynamic therapy involving photoreactive therapeutics, chemotherapeutics that become activated and cytotoxic in the presence of a specific wavelength of light. So they're out there, and I'd only say it for the sake of completeness so that we're all talking about the same things. K lasers or therapy lasers are generally designed to be non-surgical lasers, but some of the manufacturers will have adaptation kits that allow a therapy laser of appropriate wavelength to be used surgically. All right, this is where we get a little bit dry, and I tend to lose a lot of people as they nod off. It is important, though. On a basic understanding of laser physics guides a basic understanding of laser tissue interactions, which ultimately guides our clinical decision-making. So bear with me, and this is really a dumbed-down version of optical physics 101. And I don't mean to insult anyone. This is how I understand it. So this is the level of my own appreciation of the mathematics and the physics behind the use of lasers, but a basic understanding is helpful. Pretty much everything in the universe, whether it is a computer that's in front of you, the chair next to me, or the sun, is producing photons. Every element in nature has the ability to produce photons. Now, normally we don't see the chair glowing with light. That's because the photons that are being produced by random motion of the molecule, of rather the atoms in the structure, is so slow and so minimal that the number of photons does not result in something that is easily visible to our human eye, and certainly not something that we can use for therapeutic purposes. We know that atoms tend to be somewhat unstable. Now, again, depending on the medium, the atoms may be more or less stable, but there always is some flux between a more stable state, the singlet state, as you see on the screen in front of you, through the metastable state, which is an intermediate phase of stability, and then back to the ground state. So there's this normal fluctuation as atoms move about. As they move from one level of stability to another, that movement oftentimes can result in the emission of a photon. So how do we take these photons that we know that are being produced naturally, how do we take them and use them in a coherent and therapeutic fashion? So what we need to really be able to do is excite these atoms beyond what their stable state is generally accomplishing in most states of nature. And we do that by encouraging those atoms to change from singlet state to metastable state back to the ground state more rapidly. And when we do that, we are increasing the number of photons that are being produced. When the photon collides, as I said, they invariably will collide with each other all the time. Every time that collision occurs, we get more photon production. So the basic idea of a laser is to be able to generate more of those photons, but we want to be able to generate the photons in a coherent and monochromatic manner. What do we mean by that? We mean that all of the photons that are coming out of our device should be of the same wavelength, whether it's 810, 980, 2100. They all should be more or less, there's always a little bit of fudge in there, which we'll talk about when we talk about dopants. They should all be of the same wavelength. We also want to make sure that they are coherent, that that beam of light is very thin, very focused, which maximizes the amount of energy that is contained within the laser beam. So the basic schematic of a laser is in front of you. The idea is we have a lasing medium. Now that can be carbon dioxide, that can be a diode, it can be ruby, it can be gold, it can be any number of lasing elements or lasing chemicals that have been determined to produce photons of a wavelength that is usable in some way, whether it's in medical, surgical purposes, or in industry or whatever. What we then do is we add currents, we add energy to the system. We excite those atoms beyond what they are naturally doing in their stable states. By increasing current, we increase the number of photons. The lasing medium, being steady and stable and not changing, continues to produce photons of a specific wavelength. And within the device itself, we have an internally reflective surface. So those photons can ultimately be focused and condensed into a usable beam of light. Did I get everyone there? There's invariably, that's where I lose people. But it is a bit of a helpful background. We also know that we are going to be using these lasers to impart thermal injury to tissue. That's part of how we are going to create clinical efficacy. And we want to be able to understand what the laser light is doing to the tissue that is below our fiber. Initially, there's going to be a focus of complete tissue vaporization, that tissue is made into a plume of smoke and gas, and that is generally considered to be irreversible. So for instance, if you're just thinking about non-endoscopic surgery, if you're using your carbon dioxide laser and you're taking off a little benign skin tag or papilloma or something like that, we're going to fry that thing up. We are going to vaporize that tissue. Underneath that tissue will be a zone of irreversible thermal injury that will ultimately have to heal over by second intention. Below that, there will be an area of photocoagulation where bleeding will be minimized, and that is a thermal change that will rectify itself over time. And as you go deeper and deeper, you will see less and less long-standing thermal injury. The type of fiber, the type of laser will determine how large or small those particular areas of thermal injury are. It's another schematic that demonstrates the immediate zone of vaporization under our laser fiber. There will invariably be some char that occurs in terms of when we use the term carbonization, and that is material that remains unvaporized but is not viable. We can't repair that tissue. It won't heal. It's going to flake off. Below that, we will see an area, as I said, of coagulation, all reversible change or irreversible change at that point. The deeper you go, that thermal injury to vascular tissue, it has it here noted as irreversible, but again, it is very much dependent on the depth of penetration of the thermal injury. And then as you go deeper, you will see that there is a reversible, easily healable zone of thermal injury. Now, one of the things that the surgeon will ultimately want to and be able to control is the diameter and depth of the thermal injury. As you see on the right, it demonstrates what we can accomplish with a lower power use. We can achieve a much broader area of easily reversible thermal injury, as well as a broader area of easily and quickly rectifiable thermal injury. So really the take-home message is that the way you use that laser, given its frequency, determines the magnitude of thermal injury that we are going to be imparting. Now, one other comment that I should make is one of the arguments that some detractors make, and they can make this of anything that uses thermal injury, is that the tissue is always delayed in healing whenever we use heat, whether it's electrocautery, radiocautery, cryosurgery, or lasers. We are going to delay normal tissue healing. And that's okay as long as we recognize that preoperatively and we understand what we are going to be doing to the tissue and how to manage it postoperatively. One of the great examples of this, and I'll show you a video of this I think a little bit later, is doing a myringotomy. I do most of my myringotomies now with a laser. And the reason I've taken to using laser, and there's arguments that, boy, that's overkill for something like that. But the reason that I like it is, in fact, the delayed tissue healing. One of the things that is a constant bane for those of us who do a lot of otoendoscopic surgery is that once we do a myrigotomy with successful therapy, the tympanic membrane heals incredibly fast, incredibly well. I had this happen in my own family where my kid had tubes put in his ears, and by the second week, it had healed up and pushed one of those tubes out. It's great that it heals so quickly, but we want to keep that middle ear open to allow drainage, right? So that's a place where delayed thermal injury, delayed tissue healing can actually be advantageous. So it's neither a contraindication or an across-the-board indication, but it is something that if the surgeon recognizes, it can be used to our therapeutic advantage. The fibers that we use are oftentimes proprietary to both the wavelength and type of laser that we're using, as well as to the particular manufacturer. Older diodes, just in case you're out there looking for these on the used market, oftentimes will have a broader availability of available fibers. As companies have gotten more savvy and technology has become more proprietary, the fibers themselves have become more proprietary as well. Most of the fibers do have a relatively similar construction. They are a glass or silica-based solid core surrounded by some sort of silicone cladding with an SMA type adapter that goes into the optical component of the laser device itself. Pretty much, there's a tremendous variety of different fibers on the market. This is a flat beam fiber so that the beam of laser light is coming out parallel to the long axis of the fiber. This is a bulb or orb type fiber which radiates the light in a more circumferential manner. Pretty much everything that you have in your standard surgical kit can be, you will find that there's some optical fiber component that allows you to accomplish similar therapeutic interventions. Christopher, should I stop here and see if there's any questions you want to throw out to me?
Yes, I think that would be a good time. I've got one here. Actually, I would encourage anyone to send in questions. I assume everyone can hear me now, right? One question here, Dave. The diode laser, which seems to be the most popular at the current time in veterinary medicine, what are its limitations?
I'm gonna, if I could, let me put that on the back burner, because when we talk about the therapeutic specificities, when we talk about specific procedures, I think that will be brought into better focus.
Okay.
Broadly speaking, though, areas where delayed tissue healing could potentially be problematic, and I would say this is true for any laser, that is the broad contraindication. And it's not an absolute contraindication, but it is the concern. And as I said, when we talk about different wavelengths and where their strengths and weaknesses are, that will become more apparent.
Sounds good. I'm going to leave the rest of the questions then, because I think most of them are more practical like that, and you'll probably answer them in the second half of the lecture.
Sure.
So that's good for now.
Okay. One of the great things, let me get to here. This is the coefficient of absorption curve. And this, I certainly have as much familiarity with this diagram as anyone, and I have only a fractional degree of understanding of it myself. But it really drives home the point that different wavelengths of light have different photoreactive properties. And we need to be aware of that when we decide what surgical interventions we're going to be doing. Okay, well, we can use our fibers in a variety of ways. When we talk about diode fibers, and this is where some of the purists in laser surgery will get a little bit miffed. Diode lasers oftentimes will generate their thermal effect by heating with the laser light a thin layer of carbon on the tip of the fiber. You know, we talked about carbonization on the tissue. That carbon can retain and transmit heat. So in fact, when you're using a diode in contact mode, it is not so much the laser light that is doing the cutting, it is the hot tip. It is, again, if you're a purist, it is not the laser light itself that is impacting the tissue. It is this, as I said, this hot carbonized tip. However, you know, I liken it to, you know, comparing a scalpel to a chainsaw, right? The ability to control the thermal injury using these fibers is so much more specific that whether you're going to parse out words and say that it's the tip itself that is doing the thermal injury or the light, I'm not sure that's an important point. But when we bring our tip of the fiber into direct apposition with the tissue, we're going to see an immediate zone of irreversible thermal injury. We will also see excellent hemostasis, and we're going to see, again, progressively more reversible thermal injury beyond. Very, very quickly, because I don't want to spend too much time, because I do want to talk about clinical specificity. Laser safety. For those of you who've worked with lasers, you know that eye protection is critical. Laser goggles, if you happen to have a laser in your practice, laser goggles tend to be wavelength specific. Usually on the arm of the goggle, it'll tell you what wavelength it's approved for, so be aware of that. Make sure that you're using eye protection for everyone in the surgery that is appropriate for the wavelength of light that you're using. To be fair, if I put a fiber inside a body cavity, the likelihood that I'm going to inadvertently hit someone or something with that laser beam is pretty small, but certainly the folks at OSHA will tell you that you should be wearing laser goggles regardless of how you're using the laser. Laser burns, iatrogenic thermal injury is always a concern. There are special non-reflective surgical instruments that are available for open general surgery. I try and keep, again, this is more applicable for an open surgical field, but certainly if you're doing rhinoscopy or cystoscopy, any place that you might be using an irrigant, it's a wonderful ability to keep the tissues obviously moist, and that serves as a thermal sink to minimize the dissipation of thermal injury beyond the point of the surgery. We want to avoid flammable antiseptics. We don't want to douse this area with alcohol. We also need to be aware that we don't want to activate the laser inadvertently. We also want to be aware that the laser, if it is activated while the fiber is inside the instrument channel of an endoscope, can result in some very, very, very expensive damage to the devices. I rarely see these in use in veterinary practices, but for safety purposes, they do provide what we call a dead man switch or an override switch. And basically it's a device that clips onto or is installed onto the door of the operating room, which will, when opened, deactivate the laser. So you cannot inadvertently walk into the surgery room when the laser is being used if you're not, again, wearing the appropriate eye protection and things like that. The plume of tissue has always been somewhat of a concern to laser surgeons. There has been experimental evidence suggesting that viable fragments of oncogenic DNA material have been isolated in the plume. That has led to the concern about using surgical masks that are appropriate for laser surgery, using a smoke evacuator that has a filter, again, designed to remove the particulate matter. As a practical matter, I'm not aware of any clinical cases of transmission of disease through laser plume, but it is a theoretical concern, so we want to be aware of that. All right, moving on. I'm going to only very, very quickly go through this because I am making some assumptions that those who are listening to this have some experience in using minimally invasive surgery and endoscopy in their practices, so I don't want to spend too much time on this. But obviously, when we decide that we are going to purchase a laser or what kind of laser we're going to purchase, we want to see what sort of clinical caseload are we going to be seeing most commonly. Do we do a lot of endourology that would make a Holmium YAG laser a wonderful addition? Do we do a lot of upper respiratory or a BOAS surgery that would make a 980 more valuable? That sort of questioning. Training, as I said, a laser is not a laser. You have to be willing to, as most of us did when we purchased our first endoscopic equipment, we want to be willing to undertake the time to be able to use the equipment properly, to be able to deal with any complications that might arise. And as I alluded to before, a basic knowledge of laser physics, laser tissue interactions is helpful in maintaining the efficacy of your surgery. And the golden rule that I was always taught is never attempt an endoscopic procedure that if everything goes to hell in a handbasket, you're not prepared to take some action to proceed and complete in an open manner. I talked about this a little bit, but again, we want to be sure that this equipment is going to be able to pay for itself in our clinical setting. So the economics of your practice, being able to convince and educate your clientele about the benefits, offering it as a referral service, whether you are a boarded specialist or not, making sure that you have the right staff and the right physical plans to introduce laser surgery successfully. Okay, again, I'm not going to spend a lot of time going through this except to serve as a reminder that almost all of the equipment that we are commonly using in small animal minimally invasive surgery can accommodate in one way, shape, or form laser surgery or laser fiber. The fiber optic delivery system is, if unintentionally, almost perfectly married to the type of equipment that we use. You know, with the 2.7 multi-purpose set, that instrument channel that allows us to put a grasper or biopsy forceps easily accommodates laser fibers of different diameters. This is the Karl Storz Calculase. I think this is a Calculase 2. This is their version of the Holmium YAG laser. This is the one that I use. Very, very simple to operate. Has a couple of different knobs, an emergency shutoff switch. It has the ability to control power, pulse interval, things of that sort. But it really is, from a buttonology standpoint, a very simple device to use. And this is the proprietary fiber that goes with the Calculase. As I said, many of these fibers are proprietary and they are oftentimes designed for single use. Karl Storz does make two versions. They make a reusable version that I think can be ethylene oxide sterilized, as well as a disposable version. I use both. I ethylene oxide both, in contravention of what the recommendations are, but I've never had an issue with that. This is a 980 meter diode, the V30 made by IPG, and they're all basically the same. This device probably weighs about 3 pounds, has a footprint of, I don't know, maybe 6 inches by 8 inches, very simple and small to use. This is a similar version of the similar size. This is an 810 nanometer that is made by Alexion. The touchscreens are very intuitive and really quite easy to use. Let's talk a little bit about specifics. And when we choose, and this kind of gets to the question that Dr. Chambliss posited earlier, what are the limitations and advantages of different wavelengths? Well, 980 nanometers is probably the most commonly seen wavelength of light in small animal surgery. It is versatile. The devices that produce this wavelength of light are affordable. They tend to be quite safe. They behave a little more like a carbon dioxide laser in terms of depth of penetration than some of the other devices at different wavelengths. So if you have some experience with laser tissue interactions of a carbon dioxide laser, this will be a little more comfortable transition. It's wonderful in that it's attenuated minimally by fluid. So if you're doing something in an irrigant medium, the fluid that would otherwise, for instance, with a carbon dioxide laser, be rendered virtually useless, will have minimal effect on a 980 nanometer diode. And it is also very effective as a hemostatic control mechanism. It can be used, as we talked about briefly before, in both a contact mode, direct apposition, or in a non-contact mode, similar to how people use a carbon dioxide laser, where the beam is at a distance from the surgery site. As I said, it's effective in fluid and blood, but it will be attenuated very slightly. I mean, I said it's minimally attenuated. It is minimally attenuated. Anytime the laser interacts with anything, the beam is somewhat attenuated. It'll behave a little more like a CO2 laser. So the advantages are has a tremendous variability of application from rhinoscopy to lower urinary tract, upper airway. It can be used as an open general surgery laser as well. The fibers tend to be easier to find and relatively less expensive. The devices themselves, as I showed you, are quite small, so you could have one in your facility that you could easily move from a treatment area for dirty surgeries to a sterile surgical suite. They're, as I mentioned before, they tend to be cost effective. Disadvantages, they do have the ability, as do all of these devices, to cause collateral thermal injury. The minimal attenuation by water does reduce the power somewhat, but it does not by any stretch of the imagination render it ineffective. There's more of a power loss when it is used in a non-contact mode. Not necessarily problematic, but something one needs to be aware of. The harder the tissue, speaking broadly, fibrotic tissue, sclerotic tissue, anything that has a degree of calcification, it will be relatively less effective, even at high powers. As I said, nasal surgery, lower urinary tract surgery, many of these devices were originally designed for oral surgery or dental surgery. This is a wonderful device for endobronchial surgery. I've done a bunch, this is not really endoscopic, but feline eosinophilic stomatitis. It's wonderful for myringotomies and doing brachycephalic airway syndrome. This is the 980 being used in an oral, AU oral mass. This was a benign polyp, and the things I want you to sort of see here are the a degree of char that is being produced. That's perfectly acceptable. You're going to always have some degree of carbon that you're producing. The amount that is seen in that particular screen is minimal. This is an 810 nanometer diode. As I mentioned before, the footprint and the box are real similar to most of the 980s that you'll see out there. This is the 15 watt version. Now, compared to the 980, the 810 is even more minimally attenuated by fluid, can be used in both contact and non-contact mode. And its real selling point is the 810 is highly absorbed in highly pigmented tissues. So melanin, hemoglobin, this is why they're so wonderful in highly vascular surgical environments. They minimize the amount of blood loss. They are very effective, as I said, against anything that is highly pigmented. The take-home message here is that it is important to be aware of how that different wavelength of light will affect those tissues. Meaning that if I know that I'm working in a highly hemorrhagic or highly pigmented surgical field, maybe I'm going to turn my power down a little bit. Maybe I don't need 10 watts of power. Maybe because of the thermal effect of 810 nanometers on the types of tissues I'm working on, maybe I can use a little bit less energy. So that's the kind of decision making that goes into when you choose one wavelength over another. So you'll see this magnified thermal effect in highly pigmented tissue. You will see deeper margins of irreversible thermal injury. Again, a relative contraindication. You see it as a disadvantage as well, but it depends on how you're using that device. You'll get more thermal effect given the tissue with less power. It is a little bit more, the learning curve is a little tougher on the 810 than the 980. They do work similarly, but you have greater possibility of iatrogenic thermal damage, especially for the inexperienced laser surgeon with an 810. Oral lesions, pigmented lesions, hemorrhagic lesions, hemorrhagic surgical field, surgery, things like that. And anything where you really want to be able to get a very deep margin, an 810 can be very helpful. So the list of clinical indications is, again, similar to that of the 980, but I will make the choice depending on the nature of the tissue that I anticipate that I'm going to be dealing with. So I have the advantage of being able to choose the laser that I use depending on the type of tissue. Any of these lasers can be used in any of these fashions. But again, coming back to that same point to harp on, that understanding how a particular wavelength interacts with tissue will be important in terms of safety. This is a colonic mouse. I apologize, I don't remember exactly what this was. But here we are using a 980 nanometer diode. And what you can also see here is we have undermined some of the submucosal tissues with saline to give us a little better access to the base of the lesion so that we can transect a little more completely down near the surface of the distal colon. The Holmium-Yag laser does theoretically work a little bit differently. It creates, due to the high temperature, essentially a plasma bubble at the tip of the fiber. There was originally some theories that the Holmium-Yag worked so effectively, particularly in lithotripsy, as part of a photoacoustic effect, meaning that the light activated the fiber and caused high frequency sound waves, which it certainly does. And that was the mechanism of how it affected tissue. It seems to not be the most accurate description, and there still is controversy in the community of physicists that deal with this sort of stuff, but it does seem that a Holmium-Yag works generally with a traditional laser tissue interaction where the light itself is the surgical element. It provides excellent focal soft tissue ablation. It is a rapid cycling laser, depending on the setting, that allows for significant tissue relaxation between pulses, and as such, very rapid cooling, again, minimizing collateral thermal injury. And it's a great device for stone dusting and fragmentation, which we'll talk about as well. Laser lithotripsy, you can't do it. People have tried to do it with the neodymium-YAG lasers, and it's very inefficient. So it really is the device of choice for doing laser lithotripsy. Transurethral resection of the prostate, transurethral resection of neoplasia. Any place there's a stone or a lower urinary tract soft tissue lesion, it works extremely well for. If you're doing a radical laser turbinectomy, it is tremendously fast and efficient. In the United States, it is licensed for and approved for treatment of esophageal strictures. I have used it successfully with both urethral strictures, small bowel strictures, very proximal small bowel strictures, nasopharyngeal strictures in combination with balloon dilation, things of that sort. Again, rapid and efficient tissue ablation, rapid cycling minimizes collateral thermal injury, the ability to do lithotripsy. It does provide excellent hemostasis. It's very good at adhesionolysis. So if you're going back multiple times to a surgical site, it's really very effective. The disadvantages, they are bigger devices. The one I have, and I think the Calculus is actually the smallest device on the market. It's about 80 or 90 pounds, and that's small. So it's much larger than the diodes. The fibers are usually proprietary, and they're substantially more expensive, so you want to be able to take care of those. The vibration of the tip, we talked briefly about that photoacoustic effect, can spray tissue around as it vaporizes, and that is due to the tip of the fiber vibrating. So that can be a little bit disconcerting. And again, I've used this both in opens general surgery for BOAS type applications, as well as for endoscopic applications. Here we are just, again, talking about how we use the clinical indications for the different types of lasers. Elongated soft palate, again, we're not really talking about endoscopy as much now, but certainly these are the sorts of patients that present to those of us who are doing minimally invasive surgery. I'm not going to spend too much time here because we all know the basics of this. I have used both a 980 and an 810 nanometer for BOAS surgery. I have, in a couple of indications, used the Holmium-Yag. A lot of times it is the size of the patient that will dictate the type of the fiber and the type of laser that we use. Most commonly, when I'm doing any of the upper airway stuff, not necessarily just elongated soft palate, the device of choice is either a small diameter flexible scope. as well as the 2.7 multi-purpose rigid scope. The fibers themselves, as I showed before in some of the graphics, do tend to come in a variety of different diameters. So the choice of diameter is largely dictated by the choice of by the instrument channel of the particular endoscope. I've used this on inverted laryngeal saccules, both the A10 and the 980 nanometer diode. I apologize, I probably should have taken some of these out. All right, let's stop there for just a minute to see if there's any other questions. I apologize, I'm going a little bit long, but Christopher, is there anything I should address now?
You know, I've got several more questions. We could either do them now or at the end because we are running low on time. You want me to go with those questions now, or at least some of them?
If we can wait, let me try and truck through and I'll address them at the end if that's all right.
Okay, that's fine. Let's do that.
I do this less and less now because we have better access to board certified surgeons who are able to do tiebacks, but certainly I've done laser laryngectomies. It's not my preferred surgery, but the laser definitely, if you compare it to the old days when we used to use a Mayer uterine biopsy forceps to chunk out pieces of the arytenoid, this is a much cleaner way of doing that same procedure. This can be done with both the 980 as well as the 810 nanometer diode. This is another oral mass. This time we're actually using the 980 nanometer diode. In the interest of time, I'm going to skip this one. Again, you can see here the superheating of the irrigant medium and the resulting char. I'm showing you just a couple seconds of this, but you can see how rapidly we are vaporizing tissue here. It's not letting me advance. There we go. I'm going to skip through a little bit. One of the reasons I include this is to just demonstrate how efficacious particularly the 810 nanometer diode is in the nose, which is invariably a highly hemorrhagic surgical site. Whenever I have a situation where I anticipate that bleeding may obscure adequate visualization of the surgery, the 810 nanometer is almost invariably my diode of choice. All right. Here we are fragmenting a stone with the Holmium-YAG laser here in the urethra of a male dog. You can see by evidence by the fact that we're using a flexible scope here. Obviously an older flexible scope, which should be retired. I apologize, I don't know why that's not running. I like to show the lithotripsy pictures just because if you haven't seen them before, they just have a real, a whiz bang component that I find really alluring. It's a Star Wars type effect. All right. Very briefly before we finish up, I mentioned earlier that some of the carbon dioxide lasers have aftermarket flexible waveguides to make them applicable for use with endoscopic applications, I'm not a big fan. The neodymium YAG lasers are available and you can find them on the used market. They are tougher to use. They're tougher to get service for because it is older technology. I mentioned the Tulmium laser. Again, expensive, very wonderful technology. Whether it is actually at advantage remains to be seen. Blue light lasers, green light lasers. Again, this is all technology that is being used in the human laser surgical field that will be trickling down to us. I expect to be receiving a blue light laser soon that I'll be able to play around with. So hopefully I can report back as to how that works. So in conclusion, there's a synergism between the equipment that we've already purchased and the desire to introduce laser surgery. We have to consider the type of surgical caseload, our budget, time for learning, our physical plan to accommodate this sort of procedure. Again, there's a tremendous variability in the types of lasers and the cost of the lasers. And again, the value of being able to take a diagnostic procedure that we're all so comfortable and so well versed in and actually be able to take that into the realm of intervention is extremely valuable. Very quickly, my two plugs, our second edition of the BSAVA manual, as Dr. Chan was pointed out earlier, is coming out hopefully by the end of this year. I think it's a much improved version. Elise Robertson came on as an editor. For those of you who know her, know how amazing she is. She's been wonderful to work with. And Philip and I have greatly benefited from her input. So I encourage you to take a look at that. And coming up in October, COVID permitting, Colorado State will be offering their feline endoscopy week from the 26th to 29th of October. And at the end of that, and you got to look at it's an all-star lineup as to the teachers and lecturers for feline endoscopy week. It's not to be missed. At the end of that, we'll have a one-day workshop on pretty much everything we've covered here in a much more expansive and time-allowing form. All right, Christopher?
Dave, thank you, David, very much for an in-depth talk on this difficult topic. I do have a few more questions for you before we wrap it up. I'm not sure what this first one means. Which laser is best suitable for surgery? I'm not sure.
The question is, if I can interpret the question to mean which of these devices would have the broadest applicability for someone who might want to use it in a standard open surgical fashion. If that's what the question means, the answer is probably 980. That's probably the one that has the easiest transference to general surgical applications.
And that's obviously a diode, right?
I apologize. Yes, the 980 is a diode.
You know too much. We don't all know what a 980 is.
I know, and this is, with apologies, this is something to condense into an hour is a challenge. So I would encourage anyone who wants to reach out to me directly to get my contacts, and I'm happy to talk about this in more specificity and more detail, because I appreciate that some of this glosses over some critical details.
Yeah. It's difficult. It's difficult stuff. Another question: should we protect the eyes of our patients while we're operating? How do we protect them?
It's never wrong to protect the eyes. It is less of a concern if I'm doing endoluminal surgery, right? So once I get this fiber in the nose or wherever, the likelihood of me damaging the eyes is dramatically less. Further, and again, OSHA will tell you something very specific. The likelihood of a laser beam reflecting off something or directly or indirectly contacting the cornea is really quite small. You'd have to be very, very reckless to do it. That said, it is prudent anytime that you are working in the head to be aware of that. The ways in which one can protect the eyes are, there's really three that I'll commonly employ. Just to load up with eye lube, just to use a whole tube of eye lube right on each eye. That will help us in one way. Moisten gauze just over the eye, again, is if for nothing else, that it makes you remember that the eye is there, not to be cavalier about where your beam is floating around. And then the last thing is they actually do make contact lens type material for exactly this purpose that you can fit on that will keep the cornea protected during the surgery.
Okay. Holmium YAG lasers for lithotripsy. You mentioned that exciting whiz-bang factor, which we've seen before, but this question says, I have a holmium YAG and tried to break up a urethral stone in a horse. It did almost nothing to the calculus. I assume I needed different power, or was it just that the stone was too big? Now, obviously you can't know, but what's your feeling on that scenario?
Right, and I will tell you my experience with horses is very, very limited. It is probably a function of setting more than anything else. Setting and fiber diameter are probably the two factors that are most at play. So you may need to increase power and increase pulse time. That may help. I glossed over it very quickly, and I'm happy to provide it to anyone who wants it. There was that little table that showed some optimal settings. Now, those settings were specific to the calculase. I believe they were produced by Carl Storrs. I got that table from Dr. Batalla in Spain, and that gives a good place to start in terms of setting up power and interval frequency, pulse frequency for both soft tissue applications as well as lithotripsy. So there is a trial and error component to it. You start out someplace and, well, that's not working. What can we change? But that table, which I'm happy to provide, or Christopher, perhaps you can provide as well, is a good starting place for working with stones.
Yeah. Very good.
I've not found a particular stone that I've not been able to fragment. So if the question involves the mineral composition, I've not found that that's been a limiting factor.
Sheer size might be a factor. Some of these stones are huge in horses.
Well,
I don't know.
The issue there is not going to be so much as it going to not fragment it. It's a question of how long it's going to take. So yeah, that comes down to less the efficiency and efficacy of the laser than simply the stone volume. And at that point, you have to decide, is it more expeditious to do this in some other manner? There are certainly stones that are so big that I see in a bladder, for instance, it's going to be way quicker for me to just do a cystotomy or a lap-assisted procedure than to use the laser. So, again, you want to make sure that the tool fits the application.
Makes sense. I'm going to ask you one last question, and then I'm going to have to let it go. Reusing fibers. If there's a crack in the outer sheath of the fiber, will a beam get through and cause damage either to my scope or my patient?
It's a great question, and one I probably should have addressed. The answer is potentially yes. You want to make sure that the interior solid core of the fiber is not damaged in any way. Visual inspection is the first way I do that. Most lasers have an aiming beam. So similar to the laser pointer that you have for doing lectures and things like that, because the laser light that comes out of the beam that's efficacious as a surgical light is invisible, right? So it's either in the IR or near infrared spectrum. You're not going to see it. So in an effort to be able that you can actually see the beam, they will incorporate a low power laser pointer function. As you look at the fiber, if there's any crack in the solid core, you'll see some of that color coming through, whereas you simply shouldn't otherwise. So that would tell you that there might be some damage to the core. If the cladding of the fiber itself is damaged and the core is damaged as well, that's when you get concerned about about light leakage and heat leakage out of the fiber itself, potentially damaging an endoscope. What I usually suggest people do is if there's ever a question as to the integrity of either the insulation, the cladding, or the fiber core itself, cleave it. You cut it, and again, this is something we didn't go over, but many of these fibers can have the tips cut off, reprocessed, refreshened, and you have essentially a new fiber. So the fiber is not dead, depending on, I guess if it broke way proximal, it's not going to be very useful, but you can cut off a centimeter at a time, as it gets degraded, as it chips, as it gets fractured, that will still allow the fiber to be used for a long, long, long time.
Great. Thank you again, David. I think we are out of time. Once again, I'd like to thank all of you in the audience for joining us. Next week, we will be joined by Tim McCarthy, who will be discussing interventional cystoscopy. Several years ago, Dr. McCarthy told me that he thought urinary endoscopy was the most underutilized of all the endoscopic procedures we perform in dogs and cats. I believe he still feels that way, which is why he chose this topic. So I'm sure he'll have a lot to say about interventions in the urinary tract using endoscopes. Please be sure to submit your questions about this topic when you register for the event at endoscopytalks.com. That's next Wednesday, July 29th at 8 p.m. New York time. And remember, any previous talks that you'd like to see are available to view free online, also at endoscopytalks.com. Wishing you all well in your practices and, of course, the best of health during these challenging times. Look forward to seeing you next week. Thanks.
Thank you.